So my former life, I was a TAVR coordinator at a health system here in town, and so I have some experience, and so Dee and I are going to kind of talk through some things, but I am working one day a week at on the cardiac floor. I teach Susanna on Fridays, is how I like to say it, and when she needs another day off. But I also teach at the college, and as Karen said, I'm the director of the BSN to DNP program. So if you want to go back to school, come talk to me. We have nothing to disclose. Today we're just going to talk about how heart failure impacts patients with aortic stenosis. We're going to also talk about how identification of valve disease has implications in patient selection for transcatheter aortic valve replacement or TAVR, and then discuss the current minimally invasive valve replacement procedures and the nursing care involved. Here's a picture of the heart. To just remind you, we're looking here at the aortic valve. It is the last gateway, I like to say, out of the heart to the rest of the body, and that is where aortic stenosis happens. So valve disease is an increasing problem. Severe valvular disease reduces survival, and right now surgery remains the gold standard, but as we're going to talk, I think in the next 5 to 10 years, that may change and something else may become the gold standard. In this current era though, up to about a third of patients are ineligible to have surgery because of advanced age, end-stage valve disease, or end-stage body disease somewhere else, COPD, or they've had a surgery, there's a redo surgery. So percutaneous treatments are a viable option for those that are high risk and underserved because of these issues. So again, the aortic valve sits on the left side of the heart between the left ventricle and the aorta. It's the last gateway between the heart and the rest of the body. On the top you can see a healthy heart or a healthy valve, so it opens wide, it all comes together, the commissures all close, it looks nice and pink and how it should, and then the bottom one is a diseased valve, so it's not closing well, it's not opening well. I tell patients it looks kind of crunchy because it's got lots of calcium on those leaflets, and it's just not functioning the way it should and lets blood flow the wrong way through it. So 2 to 3% of the U.S. population is affected by aortic stenosis. The mortality rate is worse than any malignancies if left untreated. So 50% mortality in 2 years if you don't do something about that severe aortic stenosis. The aortic stenosis involves calcification and immobilization of the valve leaflets so they become stiff and narrow, decreased valve opening, and therefore decreased cardiac output. It is thought to be maybe from a possible inflammatory process, or it could be from rheumatic fever, infection as a child, or a congenital bicuspid valve. And this just shows how quickly it progresses. So the green chart shows that with age, not much happens for quite a while, but then once there's an onset of symptoms, such as angina, syncope, or heart failure, then there's a rapid decline and higher risk of sudden death because of all of those symptoms. So somebody could go, even if they got a congenital disorder or something, they can go for many years without issues, but then as soon as they start having first symptoms, it's rapid progression from there and potential death. And as I said, survival is about 50% at 2 years once they have had onset of symptoms, and 20% at 5 years. Surgical intervention for severe aortic stenosis should be performed promptly once even minor symptoms occur. That's the gold standard with surgery, but as you'll see with TAVR, there's some different criteria. So heart failure symptoms can be exercise intolerance. As people age, they become less active, and sitting in their chair kind of becomes the norm, but if they used to be able to walk to the mailbox and back with no problems, and now they can't hardly walk to the bathroom, that is a sign of exercise intolerance. If they develop angina or chest pain, chest pressure, heaviness, radiation, all those classical symptoms, that's a sign of, or an heart failure sign, but it could be indicating severe aortic stenosis. If they have a syncopal episode. So not many people, or the people that I had encountered, not many of them have had syncopal episodes, but I feel like there's worse outcomes if you do have a syncopal episode and have gone untreated thus far. And then dyspnea on exertion, if you're short of breath walking, or you're short of breath talking, your valve isn't functioning the way it should, and you're in full-blown heart failure. Diagnosis and treatment. There's multiple ways to diagnose severe valvular disease. It is by auscultating if you hear a murmur, but not always does a murmur mean something's wrong. I mean, in children, they can have innocent heart murmurs that we don't necessarily do anything with, but if you are, as a primary care provider, if you've been following that patient for years and years and you now all of a sudden hear a heart murmur, you'd want to get it investigated. The best way to do that is through a transthoracic echocardiogram, or just an echocardiogram as we refer to it. You can also get a transesophageal echocardiogram, or TEE, where they go down the throat and take pictures. And chest x-ray, it would more likely show cardiomegaly and not, you may be able to see a little bit of calcium on the aortic valve, but echo or TEE are the more common ways that severe valvular disease is diagnosed. So for aortic stenosis treatment, there's been great interest in TAVR since the first procedure was done in Europe in 2002. It took about 10 years for it to get here to the United States. Since then, patient selection, operator skills, and technology have improved. There are currently 2 companies that are have valves that are FDA approved, and there are several other companies that are in the works of having trials and going through approval. But right now it's Edwards Sapien valve and the Medtronic Core valve. So what exactly is TAVR? Dr. Hibbard will talk more about this after we're done too, but this is a less invasive procedure that allows the aortic valve to be replaced with a new heart valve while the heart is still beating. It's for patients who are either at high risk, so they have an STS score greater than 8, or are too sick to have heart surgery. TAVR may be an alternate for them. Or now we can treat patients that are intermediate risk or have an STS of 4 or greater. And so we'll talk a little bit more about what exactly the STS score is and what it looks at. And this cartoon is just a picture of the catheter with the valve in place, and the balloon is inflated, and so they're placing a new valve right inside that old heart valve, and that's the TAVR valve. Sorry, it's I'll show you more pictures here in a minute. There's different ways to get that valve in place. It can be through the groin, like a heart catheterization, transfemoral. When we first started, we used to do transapical, so we would poke a hole basically through the apex of the heart and take the catheter in that way, right straight into that valve. This was difficult, but it was also kind of necessary because we were working with really frail people who this was kind of their last ditch effort to have some sort of good quality of life, and so their vasculature in their legs wouldn't have handled the size of catheters we had at that time. And so we worked well with the surgeon at that time, who then would create a purse string suture, so we'd pull the catheter out and then tie the purse string, and they'd have a chest tube, and it'd be kind of like an open procedure because they had all this extra stuff. But we moved away from that, and now we have more smaller approaches, so we can do transaortic, so we make a small incision, or do a mini thoracotomy. We can make an incision right into the aorta and take it down, or we can do transaxillary, so subclavian. Some people are doing carotid, so any artery that's big enough to handle the catheter, we could potentially use to get the TAVR valve there. And here just shows some of those spots that we could access the artery to do the procedure. So how do we select patients? I feel like a lot of these patients are unique because they have unique challenges. They're very medically complex. They're elderly, they've got multiple comorbidities, they have multiple medications. They also have a lot of social issues. So many times they're here living alone, but they've got family all over the country, and that family wants to be involved in this decision-making process. And so you're calling people, you've got them on speakerphone, they're flying in on the day that you're having the appointment. And our goals of care are always quality. Quality of life is more than quantity. We're not going to make your life longer, but we're going to give you a better time while you're here. And so sometimes we have to emphasize that with people. You know, we're not going to get them to be 110. We're going to get her to 90, and she's going to have a really good life and not be in the hospital all the time. And then just the extremes of care. So you're starting in the cath lab or the hybrid OR. Some places they don't have universal beds, so they're taking them to the ICU, then they take them down to the step-down unit, then they take them somewhere else. But thankfully, here we have universal beds, so they go to one room and they stay there until they go home, which I think is a lot better for these patients because they have so many issues going on. And also palliative care. I really think a lot of them should be consulted with palliative care before they go through all this, just to make sure this is really what they want. I've seen that those family members that want this done for their family, for their mother or father or whoever, and the patient really doesn't want it done, really don't do well. The patient has to decide, this is what I want to do, I'm willing to do the rehab, I'm really willing to do everything, and I'm going to feel better. But if it's kind of forced on them, the patients really didn't thrive, and they didn't really recover well. So again, just some more characteristics. Old age, they're frail, they may have had a stroke, their EF may be reduced, they may have had a prior CABG, history of atrial fib, history of coronary disease, COPD, renal insufficiency, diabetes, you name it, they got it, we work with it. So. Or yes, like Susanna said, if they're drinking or you discover a lab value and you're like, well, what is this? And they're like, I don't know what you're talking about. Like, okay, well, we'll work with it. So, as I said, my previous life, I was the valve coordinator. So we had a designated day of clinic, and the patient would come with all of their family or whoever, and we did a workup of them. So we would do a frailty or functional assessment, and this is done sort of at baseline, and then they have to come back at 1 month after, sorry, this wasn't my laptop too, sorry. 1 month after TAVR and 1 month and 1 year after TAVR. So we would do a 5-meter walk test, pre-op, 1 month and 1 year. So we're assessing how or what their frailty is, how quickly they can walk, what their gait is like. Do they need a walker? Can they do it by themselves? Can they even do it? And so all this information kind of goes into our assessment. We also would take a picture of the patient and kind of an eyeball test. Are they looking pretty spry and healthy, or are they all hunched over in their wheelchair and not making eye contact with you, that sort of thing. We also do an EFT test, which I will talk about in a minute. We ask about their living situation, where they're planning to go after the procedure. We usually always want them to go back home if they can, but if they don't have anybody there with them, then we obviously have to take into consideration where are we going to send them when they're done to get better. Is their family coming into town that can help them, that sort of thing. Do they need a wheelchair or walker or a cane? Have they had any falls? We also do the KCCQ-12 health or heart failure questionnaire. We could do a mini mental state exam if we needed to, or a geriatric depression screening exam. So the EFT is the essential frailty tool set in older adults undergoing aortic valve replacement, and this was actually studied, or a study was done regarding frailty assessments by a team up in Vancouver, and they've been kind of at the forefront of all of this because they're in Canada and their FDA doesn't restrict them from things, but they looked at several different frailty tests, and this was the one that was found to be the most valid in predicting frailty in somebody. So they do 5 chair raises in less than 15 seconds. So you're sitting in a chair, kind of have your arms crossed, and if you can stand up and sit down in that chair 5 times in under 15 seconds, you get no points. So you're pretty active or not so frail. We'd also do the mini mental state exam, and if that showed any decline, then we could give them a point for that. We look at their hemoglobin and look at their albumin. So the hemoglobin and the albumin also became factors that we didn't always look at before, but they give a good indication of sort of their overall functionality of their body and how well their nutritional status is and how well their kidneys are working and that sort of thing. So you'd add up those points, and if they had 0 to 1 points, their 1 year mortality from TAVR was 6%, versus SAVR surgical aortic valve replacement was 3%. So the more points you get, obviously the higher your mortality would be. So we calculate the points, and this would go into the discussion we would have overall about what we were going to do for this patient. And this was also just our functional assessment, so we could record things. So we used to do grip strength, which was an indicator of frailty. We'd ask about their energy level, and then the CATS independence, index of independent daily activities. So could you give yourself a bath? Could you get dressed by yourself? Go to the toilet by yourself? Those were kind of some of the things that we asked initially, and then once that EFT test came out, then that's what I started using. And then the Kansas City Cardiomyopathy Questionnaire, the KCCQ-12. So this can be kind of a tricky thing, and I would normally ask the patient myself because I never knew what their readability was or what their literacy level was, and so it was just easier for me to ask. But it's really looking at their symptoms over the past 2 weeks. So were you extremely limited, quite a bit limited, moderately limited, or not at all limited to take a shower or a bath, or to walk 1 block on level ground, or to hurry or jog as if you were catching the bus? And so that always got everybody chuckling because they're like, I don't run. Like, I'm not going to run to catch the bus. It's going without me. So that, most of the time I put extremely limited for that because they couldn't do it. I think they couldn't do it even if they had aortic stenosis. So we asked this preoperatively, and then again at that 1 month and that 1 year. And that all this information also goes into the TVT registry, which is Transcatheter Valve Therapy Registry, that collects data and looks at all of the data from every place that's doing these, and can kind of, it's helping Medicare say that this is a worthwhile thing. And then we had a TAVR candidate summary where I would put all the information about the patient, their history, what their echo results were, cath results. So every person had an echocardiogram. Every person had heart catheterization to look for coronary artery disease. We did CT scans on them so that we could look specifically at their aortic valve, get measurements of that, know that we were picking the right size of TAVR valve. We'd look at their vasculature to make sure that their femoral artery and everything that we were going to be going through was big enough to handle the catheters. They'd get a carotid Doppler, pulmonary function test, what their baseline EKG looked like, if they had a right bundle branch block or some sort of rhythm abnormality to begin with. Would we need to put a pacemaker in them first, knowing that maybe implanting the TAVR valve would cause some rhythm issues afterwards? And then I'd input their frailty information, and this kind of was, all this was gone over then at a valve conference where the surgeon, the interventional cardiologist, anesthesia, nurses from the OR team, myself, everybody came together and went through all the results, talked about the patient, and made a decision. Yes, this is appropriate for this patient, or no, let's put a stent in this patient and see if that helps them first, and then we can reevaluate things. And then this became a part of their medical record. We also sent the cath image or the CT scan images to both of the valve companies, and then they would do renderings and give us measurements and things like that as well, based on their review of the measurements. So a little bit about the procedure. This is a hybrid OR room where most of the cases would be performed. So it's a cath lab, but it's also, if needed, they could make an incision and do open heart surgery, and everything that they needed was right there. Let's see if this will work. So this is the Edwards Sapien valve. This is the transfemoral approach. I don't think there's any sound. So they're taking the guide wire up. Sheet comes up. ultrasound catheter across the valve. Here comes the catheter with the valve on it. So they do imaging and make sure they're in the right place. They can inflate it, deflate it, reposition. Master took a coffee break there. I don't know why it's taking so long. All right, here comes the valve. So they're using a TE and fluoroscopy to make sure they're in the right place. They're rapid pacing, so now they're pacing the heart at like 200 beats a minute so that they can kind of cause a standstill so that they make sure they're in the right position. And then once they are where they want to be, now the rapid pacing, inflating the balloon. The valve is attached to the balloon, so it's just basically pushing that old valve out of the way, or the leaflets out of the way. They stop the pacing, they deflate the balloon, and now the new valve is in place, and because of hemodynamics just takes over, it starts opening and closing. The new valve, so it's on a metal frame. Each company uses a different kind of metal. The leaflets are either pig or cow pericardium, and they're sewn on there by hand. It's quite impressive to visited Edwards to see the room full of people that are making valves, and the Medtronic valve. So the Edwards valve is balloon expandable, so it has to have a balloon first, and it's bovine, it's cow tissue, so I'll stop.
In the catheter-based procedure, a physician makes a small incision through either the leg, upper chest, or shoulder and guides the new valve into position to replace the failing aortic valve. Once in place, the four-valve system's self-expanding nitinol frame enables physicians to deploy it in a controlled, accurate manner. After expanding, the new valve takes over the native valve's function to ensure that oxygen-rich blood flows efficiently out of the heart. Patients at high risk for open heart surgery who are treated with a minimally invasive four-valve device have a greater chance of survival at 1 year compared to patients who undergo surgery.
The difference between the two, the Edwards valve is balloon expandable, so it has a balloon that has to be inflated to expand the valve to open fully and take the shape of that annulus so it can start functioning. The Medtronic valve is self-expanding, so it's made of nitinol metal, which you may have remembered hearing about in The Watchmen. So it's as it heats up, as the body temperature heats up that metal up, it expands to fill that space. So it can take a better shape of the annulus. If it's more oval, even the valve could become more oval, and it continues to expand over time. So it will it makes it so that there maybe is less risk of a paravalvular leak or a leak around that valve, more so than with the Edwards valve. But now both companies are kind of working on things that are like the other company already had. So it's constantly changing. There's always new technology coming out. And the Medtronic valve is made out of pericardium. So here's a picture of what a procedure. So you can see both groins have catheters in and different things all happening. You can see they're inflating the balloon. They can tell what the pressure is. This is a picture that you would see from the fluoroscopy. You can see the TEE probe here. You can see the valve right here. You can see this person had previous bypass surgery with their sternal wires, and so they're getting ready to start facing the heart so that they can expand the valve. And this is a picture of what the valve would look like on fluoroscopy, and then what it looks like from looking down onto it. So post-op care. When it first started, we were doing general anesthesia, which was so always counterproductive to my brain, because I'm like, if these patients are so high risk and so frail, why are we still putting them through general anesthesia and all this stuff that, you know, it's going to make them better, but if they survive it. But now with new technologies, or the catheters are much smaller, everybody is a better operator because they've been doing it longer. Most people are getting conscious sedation, so it's like a heart cath. They're sleepy, but they're not completely asleep. They're given, they're injecting their groins, they're not having pain, that sort of thing. So it's much easier on them. I tend to refer to it as a high-powered cath now. I mean, it's still it's a procedure, but it's not open heart surgery, and it's not a heart cath, but it's more of a high-powered. If you think of it that way, it kind of makes more sense. So it's universal bed. Post-op care is similar to an APR or CABG in that you're going to be, you know, getting them up that evening. You're going to be walking them. They're going to do cardiac rehab. They're going to be on similar medication. They may have an interjugular catheter present that has a temporary pacemaker in their neck, or it may be in their groin. The groin side will be used with Perclose, or Perclose. So they're up at the side of the bed that afternoon. They're up walking the next morning if they don't have their pacemaker in. We do like to monitor their rhythm for at least 24 hours to determine if they do need a pacemaker. They will go with aspirin and Plavix for the first 6 months, and then just aspirin alone. We do recommend SBE prophylaxis because it is a heart valve that they need to have antibiotics if they're having major dental procedures. They will have an echo done before they leave the hospital to just assess placement and leak and all that good stuff. And then we used to follow up with them in 72 hours in the office just to make sure they were doing okay, that they weren't in heart failure. There was a couple people that felt like, well, I can just drink whatever I want now, filled up with fluid, and we're like, well, we can't really do that yet. But so, I mean, it was just a good way to adjust their medication, make sure they were taking their medication, and then to keep them out of the hospital or keep them from coming back if things weren't going right. And then they would follow up 1 month from the procedure date and have a whole slew of things done in accordance with the registry, and then again in 1 year. And then we sent them back to their primary cardiologist. So they would follow up in our valve clinic, and then we also said you need to go back to your regular cardiologist. So again, that 72 visit, we're looking for signs and symptoms of overload, looking at their groin site or their access site, making sure that is closing and not looking infected, making sure they're eating okay, they're drinking okay, their bowels are working, taking their medication, make sure they have their cardiac rehab appointment. They do qualify for cardiac rehab because this is considered a valve replacement procedure, and therefore cardiac rehab is appropriate. And then make sure that their 1 month appointment was scheduled before they left if it hadn't been there before. And check their rhythm, make sure they weren't not having any blocks or anything like that. Any questions? Yeah?
I have a question. When you said you get them up on the side of the bed, like, how long do you wait?
heart catheterization. So if they're on bed rest for 4 or 6 hours, then once that bed rest is over, then they can get up and start moving.
Okay.
How long are they usually in the hospital then?
Oh, I'm sorry, the question was, how long do you have to wait before they can get up and move if they and wait for bed rest time?
How long are they usually in the hospital?
How long are they usually in the hospital? So by the time, when I had left that position, we were averaging about 2 or 3 days. Like Vancouver and Europe, well, Vancouver for sure, they're doing them same day. Depends on how well the patient is, but they would implant them and they'd be out the door that. So it's improved greatly because we're not doing we're not doing general anesthesia. So if we did do general anesthesia, they usually came up extubated. I mean, they would extubate them in the OR and then they would be extubated when they came up to the floor, but or else we would recover them like we would a spinal cord. Anybody else? Yeah.
Do you guys have like a lot of neuro complications when you rapid pace and deploy that valve?
We have a lot of neuro complications with the rapid pacing and deployment. So, I mean, stroke is a risk of this procedure just because you're manipulating that valve with all that calcium on there. I think maybe in my 4 years that I was doing it, we maybe had one person that woke up with deficit, and maybe 1 or 2 that had a, like post-operatively had a stroke. Nothing usually occurred during that time. And the rapid pacing was for seconds, like it didn't last long. It was enough to make sure that valve was in the right place and that they stopped and continued. Do you have any?
That's the same
Yeah.
How long do the valves last?
How long do the valves last?
So I think Dr. Hoover's going to talk about this too, but actually there was an article that just came out in JACC that Dr. Olson shared with me. Currently they're saying 6 years, and that's actually measured more hemodynamically versus clinically. For some, as you know, some of these patients are going to be older, so maybe the valve would have outlived them. But you know, Europe was doing them, like I said, in 2002, I think you mentioned, so that would have been 10 years. We don't know any of their data, but this was a North American study, so that's what we have as of right now, because we've been doing it 8 years here in the United States.
You mentioned that when they're placing the valve, when they elevate the heart rate, getting the stabilization of the valve. How do they do that? Are there any negative outcomes that occur?
So when we're placing the valve and how does that all work? So they will place a temporary pacemaker to the heart and then pace the heart at 200 beats a minute or 180 or 200. So it's rapidly pacing, but it sort of creates a standstill effect like around the aortic valve, so that they're not stopping the heart per se, but they're making it so that they can visualize it well enough to know that they've got it in the right spot. And as soon as they confirm that, then they stop the pacing and the heart goes back to its regular rate. And they continue on with that. And then that pacemaker stays in place because maybe
We actually pulled ours out after the procedure. And a lot of times, each of these TAVR patients are special in their own way. And if they also go in with the EF of like 30%, you know, you don't want to be pacing them very long. So you know you have to get in and get out, which we talked about that in the pre-planning and the conference and that type of thing. But we took ours out post-procedure.
I think, yeah, we were starting to do that more. If they weren't having any intraoperative rhythm changes, then they probably weren't going, that probably wasn't going to happen later, so they would take it out. But if they noticed that something had changed, and sometimes they even decided to put a pacemaker in before they took them off the table, then they could do that. But it's just because of where the valves sit in the aorta and around that annulus that can affect the SA node and the rhythm centers that are there. Any other questions? Dr. Hibbert will be next.